Welcome to this webinar entitled The Role of Epidemiologists in Knowledge Translation in a Fast-Moving Pandemic. My name is Seye El-Khatib, and I am an epidemiologist by training and an associate professor in global health. But here I am in my capacity as the founder of the Facebook group called Epidemiologists. I would like to welcome three distinguished panelists, Dr. Peter Singer, Dr. Seye Abimbola, and Dr. Anastasia Pharris. Dr. Peter Singer is Special Advisor to the Director General and Assistant Director General of WHO. He is also Professor of Medicine at University of Toronto and co-founder of Grand Challenges Canada and the University of Toronto Joint Centre for Bioethics. Dr. Seye Abimbola is a health systems and global health scholar at the University of Sydney, Australia. He is also the current Prince Claus Chair in Development and Equity at Utrecht University and the editor-in-chief of BMJ Global Health. Dr. Anastasia Pharris is an infectious diseases epidemiologist working on scientific advice and risk assessment on COVID-19 at the European Centre for Disease Prevention and Control, ECDC, since February 2020. Prior to that, Anastasia worked for more than 20 years on HIV and epidemiology, research, policy, and clinical practice. The details for social media of all panelists are shared below in the description of this video. I highly encourage the viewers to follow them on social media. I personally learn a lot from the information they share, especially when it comes to global health and social justice related postings. For the session, I have collected a total of 11 questions in relation to the topic of epidemiology and knowledge translation during this fast-moving pandemic through the Facebook group Epidemiologists and social media. People posted very interesting questions from different parts of the world. So I will be showing one question per slide and sometimes two questions combined per slide. Then each panelist will have the chance to answer the question. The format will be question and answer, which means there will be no follow-up questions unless if any panelist would like to elaborate more, of course. So now let us begin. So again, welcome to the panelists, and I appreciate this for your time in the morning and in the late evening, wherever you are now in different parts of the world. So welcome again. And also I will leave it for you how you'd like to, who would like to take the stab on each question. Now, the first slide here, we have two questions that they were a little bit similar to each other. So I put them together and I will read them. The first question is from Karina King in Sweden. How can we communicate that epidemiology is not done in vacuum and often does not deal with absolute truths? So two people can look at the same data and come to different conclusions. Neither is necessarily more correct, but rather epidemiology is contextually grounded. Should we encourage more self-reflection on our own belief systems, culture experiences? Would this help more open and constructive discourse? And the second question from Julia Scarlett in the US. The variation across countries in their responses to COVID-19 highlights the differences in how experts define good evidence, meaning enough evidence on which to base decision. What can we consider in our response going forward when it comes to the interpretation of evidence in order to have a more unified global response, especially on topics where evidence is limited? So, dear panelists, please. Can I invite, yeah, you choose.
Should I start and then we can, maybe this is both really interesting questions, and probably we could talk for half an hour just about different aspects of these. But maybe just some initial thoughts from my side. I think that what COVID has shown us is that we've got, we don't operate, in public health, we don't operate in a vacuum. We've always known that, but I think that's been extremely evident to all of us during this pandemic. And so as epidemiologists, we're, as we usually do, looking at risk and risk assessment and how, maybe data can guide us in a certain way or another. But then the policy decisions that are taken from this, which is always the case for public health, but now it's just been so much more acute and operating globally at the same time in all places, they happen with all of the contextual factors, the epidemic situation in a given country, but also the sort of way that a given society tends to, have the age structure. Do older people and younger people interact a lot or a little? How dense is the population? And closely, together are people living in households and also in cities? And this has all impacted COVID a lot. And so while we may see the same evidence on, for example, the efficacy of mask wearing or of closing schools or as examples of different policies, countries have chosen to operate those or implement those really, really differently, I think, based on those contextual factors. And then the most important being politics and what those who are in charge of decision making in the country, how politically driven or how much it's guided by, for example, national institutes of health, and the interplay between those and the acceptance of a population to, for example, close things down and the economic risks that that's entailed. So I think there's a lot of interesting interplay there. And maybe just as a final reflection, what I think we should reflect, as individuals operating in public health on our own belief systems. That's extremely important. It's important in terms of public health training and for us to continually do as public health practitioners. But I think it's also important for societies to do this on a broader level. And I think we've seen some interesting examples of places where we have seen explicit elaboration of the fact that, yes, we know that there is a risk entailed with, for example, keeping schools open, but we're looking at all of these factors and we're making this decision, weighing different options and accepting a certain amount of risk with the policy that we're taking and communicating that in a way to the public. So I could say, I think, a lot more, but I'd like to hear what the other panelists have to say on this question. Thanks.
Shall I go next?
Please.
I mean, for me, just speaking up on a few of the things that have been said, there is certainly a big role for politics, interpreted most broadly, in how a government makes decisions based on the same set of facts. So for example, early on in the pandemic, there were countries that were able to take immediate action. In some instances, they could take those actions because the political cost of taking them was quite low. In some instances, it was low because it was in countries that had recent experience of similar problems. So the people understood what was going on exactly. So the government could say, now we have 5 cases, we are going to shut down the border. Right? In other places where there was much less of such a recent memory, it was a difficult decision for governments to take. And I think quite often us researchers and numbers people discount those really important consequential factors that are playing in the minds of decision makers. And I think if we understood that, it would help us better frame the kind of evidence we are producing and also preempt the thought processes going through the minds of decision makers as to how they may then weigh the options that they have. The other point that I think is worth making is that as epidemiologists, it's important to recognize that not everything that's important can be measured. There are lots of things that go into thought processes and decision making that you just can't quantify. And being alive to that fact is really, I think, very, very important. I'll stop there.
Thank you, and it's great to be with Anastasia, and Seye, and Ziad, yourself. Thank you for bringing us together. On these 2 great questions by Karina and Julia, let me just land on 3 words, maybe a little bit more than 3 ideas. One is the first word there in Karina's thing is absolute truths. And I think this reminds us of the importance to listen carefully to each other, to understand each other's perspectives across a diverse range of voices, and to do so with humility. The second word I'd like to land on is context, contextually grounded. I think this reminds us that we really need to take multi-method approaches, both quantitative and qualitative, because context really matters. And certainly at WHO, weekly health ministries come together to do peer-to-peer learning and understand essentially the case studies of each other. And this type of peer-to-peer learning is extremely important. For example, last week, the health minister of Papua New Guinea was describing the experience of Papua New Guinea with COVID, the early vaccination, and so on. And so it's very transparent. Anyone can go to @WHO and see those experiences. And then finally, in Julia's quote, I'd like to land on the word variation. One of the really shocking things, and we'll talk about hard data, soft data in a moment, but one of the really shocking things is if you go to Our World in Data, you see a 50-fold variation in cumulative mortality among even G20 countries, at least 50-fold. Now that's a bit of hard data. And so you really have to ask yourself, what are the causes of that variation? And then we get into the type of discussion maybe that Seye was talking about a moment ago. And that reminded me of the work when I was training in epidemiology and health services research and public health of Jack Wenberg and the small area variations within regions. Well, these are large area variations within countries, but the large area variations are very large and they need to be explained. And some of the explanations will be coming up in some of the questions that you'll get onto, Ziad. So I'll stop there and just look forward to continuing the conversation.
Thank you very much. This is a question from Homa Momen from Iran. During this pandemic, we have learned that in communities where there is social cohesion, the observance of preventive measures such as social distancing, hand washing, using facial masks, and vaccination through collective harmony and unity of action is more successful. Most epidemiological studies ignore issues related to social and even global cohesion. How may we further promote or strengthen these actions in the future? Who would like to start? Seye, can I invite you?
Okay, good. I'll make it start. So I think that COVID-19 has been an opportunity to learn about ourselves, whether as individuals or as countries or as the globe. And one of the beauties of epidemiology, I think, is that an explanatory factor often does not emerge if you don't have something related to it that you're trying to explain. And what we've seen with COVID-19 is this kind of different patterns of outcomes playing out in different countries, which then has allowed us the opportunity, I think, to think more deeply about the ways in which different countries differ from one another, different societies differ from one another. And of course, if there's one of the lessons to learn is certainly that social cohesion and harmony at the community or national level plays quite an important factor. Plays quite an important role, and I hope it's a lesson we will take into the future. But I think another important thing to mention here is the role of equity or inequity, as it were. That one of the underlying factors behind a lack of social cohesion and collective harmony in society is inequity. We've known that for a while. I think we've been reluctant to take that as seriously for a while. But I think COVID-19, if there's a lesson to take from COVID-19, it is that underpinning social cohesion is a certain level of equity. Now, which also then translates to mean that equity is in itself a kind of vaccine when you think about it. That the more a society can band together to solve a problem, the less they suffer And I hope that that's one lesson we take forward into the future.
Maybe I could just follow that up, Ziad,
Yes.
but comments flow from there. As Seye said, if there's one lesson from COVID-19, it's equity. If there's, or inequity, as he said, rightly. If there's three lessons from COVID-19, they are equity, equity, equity. And I also thought the link he made between equity and social cohesion was extremely important. So just want to thank him for those comments. Look, you know, this quote reminded me of the late 1980s when I had the extreme privilege of training in epidemiology as a Robert Wood Johnson clinical scholar at Yale with the late Alvin Feinstein. And one of his main contributions was hard data, soft data, and in his book, Clinometrics. And that was at the clinical level. It was the soft data patients. But this question is about the public health version of hard data, soft data. What's really so important and interesting about I think the epidemiological data around COVID is when you look at the variation in cumulative mortality, it's across countries. It's not explained by what we thought it would be explained by. It's not explained by the Global Health Security Index. It's not explained by the IHR core capacities. It's not the active capacity alone. It's the dynamic decision-making, I think, that really explains it. And in fact, you know, the thing that is best correlated, and this gets to the point of social cohesion, is trust in government. And so that social cohesion, the social capital, the trust is actually what best explains the variation in cumulative mortality, which is a form of soft data at the public health level. And I really thought it was very interesting what Seye said about equity being a vaccine. And of course, I agree with that. What promotes social cohesion and what promotes equity, and actually what promotes lower mortality rates, is leadership. And so I've written something similar. I've written that leadership is the ultimate vaccine, not only to the pandemic, but also to the interlinked global challenges, climate, racism, economic inequality, the health and pandemic issues, all of which are intricately interrelated. And in a sense, leadership is the final common pathway. And that's why I refer to it as the ultimate vaccine. But I'll think more about the link between leadership as a vaccine and equity as a vaccine, and just offer my respect and appreciation to Seye for making that very interesting point. Thank you.
Thank you.
Thanks, Seye and Peter, and also to Homan for the question. It's really interesting. I fully agree with the comments already made on equity, and think that what we have seen in this pandemic is exactly as Peter points out, leadership demonstrated in different ways. I think also it's important to say that we've understood that legal frameworks have been very different in place across countries, and I've seen that in work at ECDC, where we're working with countries in the EU. Even in that part of the world where one would expect there's maybe not such big differences, we've seen enormous differences in terms of the legal frameworks and also the relationship that governments have with the populations in terms of what is expected, in terms of these trust building frameworks, and the level of top down versus maybe bottom up, or trying to convey something to a population without a law so that they'll do it anyway. Which is an interplay between sort of leadership and government, and we do tend to see that this is based on other things in society and policies which promote or sort of hinder equity within the populations. I think that we can use this going forward to try to strengthen the approach. In public health, people do on individual level and on group level things when they understand them, and we need to work better in this way. And in the field that I come from, in HIV, we've been working with this a lot, and particularly in the last 10 years, where people need to understand their risk in order to employ the most effective prevention measures like treatment, like pre-exposure prophylaxis for HIV. It's the same for COVID. And so where populations have been, given the facts, things have been explained to them, and where they have the possibility to telework, to remain at home, to implement hand washing, to wear face masks, they usually do when they're supported in that, and when the sort of other policy systems align with that. So I think that these are important things, and I hope it's not forgotten when this pandemic, hopefully soon comes under control in most of the world, that we continue and strengthen this approach in other areas of disease, both infectious and communicable disease. Thanks.
Thank you, Anastasia and Seye and Peter. This is really so profound answers. Now, this slide here, we have two questions that I felt there was an overlap between them. First question is from Seye Abimbola from Hungary. How to manage the COVID-19 infodemic? And the second question is from Wadi Malu from Austria. During a fast-moving epidemic, epidemiologic knowledge was transmitted through scientific journals, but extra effort from epidemiologists was made to digest this knowledge through social media in an easy-to-understand format for everyday people, including infographic support modality, running sometimes almost in real time. This was, however, competing with social media mis or information being circulated from non-reliable sources. What have we learned in terms of translational science simplification and dissemination through social media to counter wrong information? Pros and cons. Since we are rotating here among our panelists, can I invite Peter to start?
Yeah, and I'll be very brief because I'm very interested to hear what Anastasia says about this. Her answers have been terrific. Just very briefly, the infodemic isn't about information, it's about trust. On social media, I'm a fan of social media. You can see the, it's a great way to learn. It's how I've learned about things that are published in scientific journals. It gives you the punchlines, sometimes the tables. And that's very helpful, actually. And then you can go into whatever depth you want. And I'm at Peter A. Singer, by the way. And the other thing I learned as we went along is and this relates to the infodemic, is the reach of gaming companies is maybe 10 times as big as the reach of even social media companies. So WHO information, WHO validated information has been sent down gaming company channels, which has reached billions or even tens of billions of people, and as opposed to millions or even hundreds of millions. And that's something I learned about social media as the pandemic unfolded.
Who would like to be next? Seye?
Yeah, I'm happy to go next. As I'm speaking now as a journal editor, and one of the things that I learned very quickly at the beginning of the pandemic was that a lot of the most important, consequential knowledge that was being produced were getting to decision makers before they got to journals, right? So in many instances, a manuscript arrives at my desk, and I'm aware already that it's already on the desk of a politician, a decision maker, a cabinet, such that for me, I mean, it was a kind of humbling moment, really, because in academia, we like to think that things follow a certain path, but COVID-19 shows us, and I don't think it was peculiar to COVID-19. It must have been the case before COVID-19, that a lot of the most used knowledge will arrive on the desk of the users before they make their way to journals. And so for me, that was an important revelation that I think it's worth acknowledging openly so that everyone is sort of thinks about things in that way. Another thing, just speaking to both questions that I found useful, again, a very social media initiative was something that Maju Pai and a few other people have done to organize education sessions for journalists on social media, sort of, well, it was initiated on social media, but it became a whole package of training for journalists, and they've done, I think, 2 or more episodes of that already, and I think they will do more. And for me, that is one of the ways in which we may preempt the misrepresentation of evidence that often happens. Another thing that I think is important is for academic journals themselves to have a kind of lay summary again, mostly for social media purposes, so that you can tweet a table in which the paper has been explained by the authors or by some specialist journalist for a lay audience. So that it's also easy to communicate the nuances and the uncertainties, because those are the most difficult things to communicate in a paper. The evidence itself, what you found, it's very clear often, but then how you nuance it from one level to another for different audiences becomes the complex thing. So I think going forward, one of the ways in which you think about dissemination is to educate journalists, but also to really work towards academic journals themselves having accessible versions of the papers that they publish.
Thanks, Seye, and also Peter. This has been something that has affected my work a lot personally, and also my colleagues at ECDC, as well as I know colleagues at WHO, where, you know, as you mentioned, Seye, like just the pace of what is coming out has been incredible in COVID. I think there's been an amazing amount of sharing, both what we've seen in the preprint literature as well as in sort of these peer transfer sessions. There are a lot of different networks, many different meetings where academics, policymakers, and others are really sharing openly emerging results, and that's been extremely exciting and a really nice thing, I think, in public health. But what this means is that we have this tidal wave of information now, which is quite difficult to sort through. We are in a situation where a lot of the information that we're using to try to inform policy is not yet peer reviewed. And I do believe in the peer review process. I think what you're saying, Seye, is extremely important. And we need to, that's been a big challenge for us at ECDC to essentially try to sort of informally have a few people look at papers that are not peer reviewed, because we're including a lot of those in risk assessments that we do, in technical guidance that we're giving to policymakers in the countries that we work with. And so it has shifted a lot of work to us that I think has been done, you know, by us and many others as peer reviewers. And that's been a challenge and has been really difficult in terms of human resources for us. I know that's been the case for some of the colleagues that we interact with at WHO as well. And so, and then we're even at a point where we're getting information from Twitter, which is being posted, which is not yet even in a peer review or a preprint article. And so it's difficult. I think that the compiler of information role has been extremely important in this pandemic. And so people who are able to, you know, take all of these sources. I found, you know, some of the people that I follow on Twitter who will, you know, sort of bring something together on asymptomatic transmission of COVID and say, I'm going to do a thread on this. And, you know, they'll bring together input sources. I appreciate that so much, because then I can myself go look at those sources and, you know, sort of try to make sense of it for myself. That's been really useful. I do think, though, where I'm working, it's still important that we're evidence-based. We're working now on a living review on the variants of concern for COVID. And so we still need to document that we're going to look at the peer-reviewed literature. We're going to look at peer print literature as well. We're going to have a process where we make sure that what we're using is the most recent article, because what we're seeing sometimes is information in a maybe National Institute technical report, which ends up in a preprint, which later is published, and things change along the way, and that also can be quite challenging. And when we're looking at, you know, maybe something important on how transmissible the B.1.351 variant might be, it's important that we get that right, because then that's been picked up and used in models for, you know, different public health policies. And so ensuring that we have processes that are transparent to follow these things is very important to us at ECDC, so that we can document to say we're opening up, we're not just doing a systematic review in the traditional sense, we're including these other sources, but these are the checks we have in place to look at these things. And then it means we have a commitment to update that living review going forward, which is also a very large amount of work, and really needs to, it's a trade-off, because we haven't received many additional human resources in our organizations. And so we're trying to balance all of this. So I think it's something that maybe I don't have an answer to yet, but that we're dealing with a lot. And I think that being as transparent as possible and still trying to, you know, to recognize the really important role that organizations like WHO have, that ECDC plays in the European context, to try to make sense of the mountain of information and point people in the right direction remains really extremely important.
Ziad, do you mind? Oh, sorry, do you mind, Ziad, if I just build very briefly on the comments of Seye and Anastasia, the great points. We're talking about the utility of open access, and I'm an open access advocate from way back, and clear communication, et cetera. But I think it's also worthwhile, and I'm sure Seye and Anastasia will agree to, and you will, Ziad, to touch on the dark side of social media. So, you know, another lesson of the pandemic is that character really matters and kindness really matters. In a sense, social media is an X-ray of your soul. It's an X-ray of your character. And what you sometimes see in some of those threads, even that Anastasia was mentioning, is then somebody attacks. And it's always a great idea to attack the substance, because that's the core of scholarship, is disagreement. And that can play out on social media. But it's not okay to attack the person. And we often see ad hominem or ad feminem attacks. And some of those really do go beyond a level of discourse that one would want to see. And I just thought it would be important briefly to touch upon these issues of character, of kindness, how social media sometimes brings out the dark side of people's characters, and how important it is to be just as kind on social media as it is face to face, and to focus on the substance of people's arguments, not the people themselves.
Thank you so much for this. Yeah, please.
Just one more thing on top of what Peter has just said, which is that for me, one of the virtues of the kind of role that Anastasia and Peter described, of academics who actually who explain things on Twitter in threads, is the ability to come back and say, I got this one wrong. And I've seen people do that, and I have a lot of respect for those who do that, because I think it's part of the process, being able to say, my analysis there was wrong. It was only specific for this kind of place and not for this other kind of place. I think it's an important thing to highlight.
Yeah, just to tie that back to something we said before, leadership doesn't just happen at the head of state level. It happens in communities, it happens on Twitter, it happens among our colleagues. Ziad, you're showing leadership by pulling this thing together. And you know, to Seye's point, one of the important characteristics of leadership is honesty and being able to acknowledge when you've made a mistake. And so I just want to fully endorse what he just said.
Thank you, Peter, for your kind compliment. Okay. This question is from Professor Aouni Aoufeso from Emirates, UAE. COVID-19 vaccination is an essential tool for addressing this fast-moving pandemic. However, the efficacy of some vaccines, for example, Sinovac and AstraZeneca, have been questioned, and at least one COVID-19 vaccine has been linked with rare, which is 4 cases per million, but occasionally lethal blood clots. Which epidemiological tools may be refined to better ascertain vaccine effectiveness and safety? Who would like to take a stab on that to start?
I can start, but with the caveat that I'm not really working on these aspects of COVID. So I have other colleagues at ECDC who are much more able to get into the details of the vaccine effectiveness studies. I do think it's important, though, to step back and say it is amazing we have vaccines at this point, you know, 16 months into this pandemic. Like, that is incredible. And I do think largely, although this is not a blanket statement that applies everywhere globally, but in the context that I'm working in Europe, I do think that we have vaccine effectiveness and safety tools in place, or you know, the platforms in place. The problem is that we've never before been in a situation where we've developed a vaccine, it's gone through clinical trials, and then we've rolled it out globally so quickly. And so usually there's a little bit more time to accumulate this, you know, safety signals, evidence, and that's what we're seeing now. We always expect safety signals with all types of vaccines, and we see them with all types of vaccines. But so far what we're seeing, you know, the levels are very, very low, and it's, I think, a positive thing that we have captured signals, because that means we have systems in place that are doing that. And so we're really at a point of tension now between trying to make sure that things are safe, making sure that people believe that, you know, due diligence is being done in terms of following these up. And I think we saw a good example of that this week in the US with this very public open dialogue that the FDA committee had in describing the Johnson & Johnson vaccine, where it was aired publicly and the data was given forward, and they said we need a little bit of time to study this better, to see what's happening with whether there are any other cases that we have not yet detected. And so then that's happening on one hand, while on the other hand, we're rolling out vaccines which are very much needed in a situation where I think we're in the 4th week of increasing deaths globally. So we don't have time to completely stop and continue to study things for a year. It's a very, very tough situation for policymakers right now. Thanks.
Who would like to be next? Peter?
Yeah, so one of my family members got one of these vaccines that was implicated on the safety side 2 days after she got it. So I thought about this a lot, and I thought, okay, well, what has been useful to me as I've been reflecting on it, and it certainly helped to know the epidemiological data, to know that the risk at that time was 1 in a million. I knew more cases would be found, or I also assumed the denominator would change. So I thought that 1 in a million would bounce around. I found it helpful to know what the time frame was, the window of the cases, and I could focus in on that time frame and when it was over. But what I maybe found most useful was actually the data visualizations, and 2 of them. One was the comparison between this risk and other risks. So for example, when you compare the risk, even visually, of safety concerns with some of these vaccines, with, for example, the risk of taking birth control pills. The risk of these vaccines is actually quite a bit smaller than taking birth control pills, let alone the risk of getting COVID, which of course is the most relevant comparison. And to that latter point, I saw another data visualization that was broken down by age, which looked at the kind of benefits. It visualized the benefits at each age strata of not getting COVID versus the risks at that age strata of the safety concerns related to a particular vaccine. And so I just wanted to relate a real life example, a very personal one in my own family, about what I found comforting and useful in terms of the descriptions and visualizations of various bits of epidemiological data that really helped me contextualize what was going on and put it into context and actually feel much better. And that, of course, takes us to the future issues. And I think studying historical examples like rotavirus and intussusception, and how that affected the rollout or non-rollout of a disease that kills, of a vaccine against a disease that kills so many people around the world. That's a similar case. And so I think those historical examples are very important. And all I want to do here is tie this question of communication of risks and benefits to the issue of equity and to the issue of global equity that Seye raised earlier, because those 2 things are connected by the policy decisions that we take.
I have very little to add to what Anastasia and Peter have said, but just to speak on a point that Anastasia made about how we're in a very unique situation here. I don't think that is the question of new epidemiological tools, but rather that it's a unique situation. We are doing a phase 4 trial on a global scale, pretty much. I mean, and of course, these kinds of issues are going to arise. And so it ultimately is about decision making, about communication, about openness and honesty, and being alive to community concerns and responding to them appropriately, I think.
Thank you.
Yeah, can I just add one thing I thought
Please.
of as now as Seye was speaking is, I think we also have a chance to ensure, we are rolling something out globally now. Let's make sure that globally we do have vaccine effectiveness and safety platforms in place. And this is something that, exists in many parts of the world, but it doesn't exist everywhere. And this vaccine should be rolled out everywhere. And there are, platforms like COVAX and others which are trying to promote that. But let's, together with that, I know these discussions are happening, but I think this is a unique opportunity to really strengthen our systems on the back of this pandemic that can be a benefit to global health going forward.
Thank you very much. Now we move to a question by Amelia Lundqvist from the US. During last year, we have relied almost entirely on technology to communicate to our patient population, predominantly via emails, messages in English, through Patient Gateway and an app. Many patients, however, are not tech literate, don't have internet, or have a smartphone, or even a phone, or don't speak English. There are some community-based efforts, particularly around vaccine information, but I still hear about a lot of hesitancy and skepticism from patients, staff, and general public in Boston and the US. How have other countries addressed this, both the technology and trust barriers, and have they leveraged KT in certain ways? What worked well and what can we learn? Who would like to take a stab on that?
Let me go first here, and I'll try and be brief. So I straddle, I have this mixed identity of being a Nigerian who is still very connected to Nigeria, and my family is in Nigeria, so I get Nigerian news every day. And also being in Australia as a minority / immigrant, and also occupying that peculiar space. So first about technology, I think old technologies are still very, very great and useful. Radio in particular, in Nigeria, radio is and continues to be a very, very useful technology to reach rural areas, and putting programs, putting information on those platforms, even for people without mobile phone access, has been very useful, continues to be very useful with the response in Nigeria. In Australia, one of the things that I noticed, I'm part of the not very large African community here, and the government has made several efforts to reach out to people that may be deemed leaders in that community through Zoom calls and sort of feeling the pulse of our communities in the country through us, through people who connect to a broader range of people, and sort of including the rumors. When we have these sessions, I mean, they ask about the rumors. What are people saying? Just so that the health department understands how to pitch its message to that particular community. And in many instances, what I find interesting is that the rumors in the Nigerian community in Sydney are the rumors in Nigeria, in Africa, sort of Nigeria. So there's this interesting connection between what's on WhatsApp groups of families in Nigeria and what's on WhatsApp groups of families of people in Australia. And I just find that particularly interesting, the globalization of information, but also how you have to localize your response to how to manage these things.
Thanks, Seye. That was really interesting to hear about, and I can only agree. I think that what you've already picked up on the importance of understanding who leaders are, informal leaders and formal leaders in communities, and trying to really dialogue with those persons is probably the best way to handle this. But it's extremely challenging. I think also it's important to acknowledge that as epidemiologists, our partners that work in social epidemiology, but also social scientists are extremely important here. And then we have a possibility, and again, I'm speaking more from like work that I've done in HIV. We've found that partnership with, for example, people that work with dating apps has been extremely useful in terms of understanding how we should tailor our messages. And so partnering in some cases with people from the private sector who really understand messaging and understand human behavior, I think much more than we tend to in maybe more classical epidemiology, is important and can be leveraged, I think, much more. A lot of countries are still scratching their heads and trying to go back to vaccine hesitancy campaigns that they've used for measles, and now rolling something out to a much larger population there needs to be a tailoring of those strategies, because it's not exactly the same types of questions that people are having, and it has to be extremely proactive and reactive, and constantly understanding the rumors that you mentioned, Seye, but also figuring out how to address them, and as we've touched on previously in this discussion, kind of the trust building, and leadership plays a big and important role there. That's it on that one. Thanks.
Just great responses. Just to add that these information issues are not about information, they're about trust. Communities are critical and community leaders are critical. A good principle here is nothing about us without us. And as a concrete example, I'm hoping that, for example, the rollout of the vaccine in Indigenous communities in Canada will show a positive chapter. Because there's been a lot of engagement of community leaders and Indigenous people who are physicians, engaging with those communities. And I'm hoping that that will be a positive example when the history of the pandemic is written against what can only be described as a shameful panoramic history of relationship with Indigenous peoples. Yeah. And I think there's a lot of lessons that can be learned in real time across different types of communities, but each is unique and leadership is important.
Thank you. Now we have a question from Anya Busse from Vienna, Austria. How can we ensure sufficient attention to data collection on substance use and substance use disorders, including drug use and drug use disorders, in efforts to collect epidemiological data on health, including mental health outcomes during and beyond the pandemic in low and middle income countries with often weak data collection systems? Who would like to take a step? I see, Anastasia, you unmuted yourself. Please.
Yeah, I'll say something, but others can add. I think that this is one of these things that's a bit of a chicken and the egg problem, because we also know that services in a lot of low and middle income countries, as well as high income countries, are quite weak in terms of provision of services to address mental health issues or substance abuse disorder issues. And so if we don't have data, how can we advocate for those services? But at the same time, should we be focusing a lot on collecting data instead of advocating for the services? So I'm a little bit torn in terms of the best place to start. I think that that data can be used though for advocacy, and this is a huge issue everywhere globally. And I think we've also seen during the pandemic, there's been a bit more focus in some sectors on increased, for example, overdose, for example. So I think though, in terms of trying to improve data collection systems, the question from Anya, who works at UNODC's had a lot of leadership there. There have been some good examples of harmonized data collection issues or indicators that are being used across a lot of countries in terms of what is problem substance abuse, how do we define this, and how do we measure it. But a lot of those are measured at places where people access services. And so again, if we don't have the services, how are we measuring these things? Ziad, you yourself, I know, have done interesting work on strengthening of systems through mobile phone data collection on surveillance. So it would be really interesting to hear your views on this and whether this could be translated to these areas. But I think that maybe trying to have very simple indicators to collect the most important things on mental health and substance abuse in such settings, but really attaching those to advocating for services then to address them would be important.
Peter, I see you are on mute, so that means you would like to be next, or say, I say you unmuted yourself, so please.
Hey, go ahead.
I was just going to add, I will focus on the data collection systems part of the question. And there are a few things that I am absolute about. And one of them is data systems. And I say that partly as a journal editor who receives lots of papers that I know deep within my soul should there are studies that would never have been conducted if there were good data systems in the country. And there's a part of me that wishes that there was a rule that says, do not conduct such a study without strengthening the data system in the place where you've conducted it, almost as a price for conducting such a study. I wish we get to that kind of place in global health, but I do believe strongly that there is no alternative to strengthening national data systems. And it's one of those things that, you know, have a lot of dividends, including such things as substance use abuse and mental illness data coverage.
Yeah, and just to build on those wise comments, you know, when I came to WHO in 2017, and we were working on the strategy, the triple billion targets and the measurability of those targets, I came here thinking indicators were more important than data systems. And now I realize I was wrong and the data systems are more important than indicators. And that's an overarching point. Since that time, WHO in its transformation under Tedros has actually created an organization-wide division of data and delivery for impact, led by Dr. Samira Asma, who's a terrific colleague, and I would encourage everyone to follow her on Twitter, anyone who's interested in data. Dr. Asma in that division has launched something called the SCORE technical package, which is essentially an X-ray of data systems in every country in the world, and country-specific indications of different types of data systems. You know, for example, counting births and deaths is the C. Surveys, vital statistics, you name it. In the context of this question, I think the important thing to zero in on, and it goes back to the lessons of COVID, is equity and the fundamental importance of disaggregated data systems and disaggregated data. And that is of vital importance. Disaggregated data is of vital importance if we're going to understand the inequities that we've been talking about in this session. And if we're going to use those data to redress inequities, which after all is really the only point of measuring them. And a great concrete case example of that, and there are probably many, but is the work of Kwame McKenzie and others in Toronto, and the use of disaggregated data and actually the increased collection of disaggregated data around racialized communities and hospitalized COVID rates, where racialized communities are very, very overrepresented early in the pandemic on hospitalized COVID, and how that data was used, A, to collect more disaggregated data, B, to target in on vaccinators from racialized communities, postal codes related to racialized communities to vaccinate, and then ultimately the move to, which is still, I would say, very much in progress, social protections, focus on essential workers, the type of social supports needed to reduce rates of COVID in those racialized communities. So postal code matters, and social determinants matter, and equity matters. And without disaggregated data, you're flying blind.
Thank you. Now we have this question that when I saw it, I felt I have to put this question because I found Ahmed Abu Khair, who is a 13 years old school student from Jordan, and I find it very endearing for me. Tons of information are sent every second, and it is important not to regulate the information for people, but to teach people how to regulate information by themselves. Example, the weather forecast. When meteorologists say there will be a massive storm tomorrow, you won't see people screaming and shouting that the meteorologists, they are wrong and that storms are not dangerous. Instead, because people know the kind of damage storms can cause, they can come to a conclusion for themselves without the need for meteorologists that storms are in fact very dangerous. How to educate people that pandemics are dangerous and to distinguish between false and true information during these times. I see everyone smiling.
Yes, I love the question. I can say a couple of words. Thanks to Ahmad for the question. It's a really good one. And I think this is important for the pandemic, but it goes beyond the pandemic. And, you know, as young people and everyone else are exposed to many different sources of media, social media, we no longer have, you know, so much control over the message. And so we need to educate and empower our young people and our sort of all of our people to, and ourselves, to be more critical, you know, better critical thinkers and consumers of what they're hearing. And an example, I have 11 and 14-year-old children, and even just this morning, one of my daughters was watching something on TikTok about what should you do if you are attacked by leeches. I have no idea where she found this. So I was listening and I said to her, so honey, how do you know that this is good information? I mean, who is this person who's providing the information? She said, oh, mom, it's someone who knows a lot about leeches. And, you know, this is what they've said. And this is, you know, I just want to be prepared in case it ever happens. And I thought it was funny, but it was just, you know, a moment to ask, you know, how do you know this is an expert? How do you know what they're telling you is correct? And how do you, you know, having dialogue around this? And I've noticed that this is starting to be part of school programs, but I think it's important that, you know, that we all, you know, ask our peers, oh, a friend cited the statistic, where did you hear that? You know, how do you know? What, how do we, you know, with a little bit of taking things with a grain of salt and trying to understand the sources that we're getting information from. But I really like the example about the weather that Ahmad gave. And I think it's true that in many situations of life, people are able to do this very capably. And why do we have these certain areas where then it seems that there's more false information coming through? Those are my reflections.
What I find very striking about Ahmad's question is that it speaks to how the human mind works fundamentally. That there is, I think, still a lot to learn about the behavioral psychology of how we assess and respond to risks. There's a friend of mine, Sanjuti Saha, who is a microbiologist, tweeted a few days ago. She's been involved in the COVID-19 response in Bangladesh very heavily. She tweeted that she wishes people would use face masks, understanding the risk of COVID-19 as much as they are afraid of the risk of adverse events from taking the vaccine. Right? And for me, it's just another interesting example of juxtaposition of how people think about what is risky, what they should be afraid of. And I feel as though one of the lessons of COVID-19 is to take this behavioral psychology of the human mind's assessment of risk seriously in how we plan for future pandemic responses.
Thank you. I mean, well, first off, thank you, Ahmad. You're really showing the importance of young people. And so thank you so much for your question. Secondly, you know, to take a page from your book, what I would say to everyone is if you don't yell at the weatherman or the weather woman or the weather person, don't yell at the epidemiologist. And thirdly, I think that lived experience really matters. COVID's the worst crisis certainly global health, certainly acute crisis in 70 years, maybe the worst global crisis. The worst global health crisis in 100 years, maybe the worst global crisis in 70 years. And lived experience really matters. So, you know, in 2015, when we launched the SDGs, it was like, leave no one behind. Yeah, whatever, leave no one behind. You didn't really feel it. You knew it was important cognitively, you didn't feel it in your heart. I think everyone now hopefully should feel the importance of equity, of solidarity, and of leaving no one behind. And that's the best way to distinguish different types of information, is that lived experience. And sadly, I think everyone in the world now has that lived experience. Especially in the context of equity, or as Seye said earlier, inequity. You just have to be open to seeing it and feeling it.
Thank you very much. And now this is our last slide. This question is from Alain Ahishakie from Rwanda. Can we predict when will the future pandemic occur using data from the virology field? And another question that I felt also did overlap is from Soha El-Halabi from Sweden, what are some positive experiences or lessons learned from the pandemic that epidemiologists can build on as they carry KT activities post-pandemic? Or is it too early to ask?
I can start. Yeah.
Please.
So for the prediction, I think what we've been hearing, or I've been hearing, from colleagues who work with pandemic preparedness since I started at ECDC, that anytime a pandemic could happen, and they were really waiting for it, they expected it, and it came. And I don't think that means that it will be another 20 years or 10 years. I don't think we can predict when this happens again. I hope we will be more prepared. Even though we had pandemic preparedness plans in most places in the world, we found in many cases those really weren't very well adapted for what we experienced. And so we need to use these lessons, and already this is happening with sort of these in-action reviews and after-action reviews to understand how we need to improve our systems. So I hope we will be much better placed to meet any future pandemics globally. And so I think that's one positive experience, is that planning works, but we need to, it really needs to go at all levels and not just be a plan that's kind of there on a shelf, but needs to be ready to adapt to things, especially where I think a lot of the countries were basing their plans on influenza. And we've seen that there's a lot of similarities, but a lot of differences with COVID. And so we need to really have a little bit broader and more robust plans. I think there's many positive experiences actually that we can learn. I'll just mention a couple. We've touched on information a lot earlier in this discussion, and I think that this has been an incredibly positive thing, that we have had so much information sharing and really nice collaboration across academia, across epidemiology, across policy and communities to quickly share information, to try to understand and communicate information quite rapidly, and I think in a really open and collaborative way. And so that's been really incredible, where I've seen, again, to reflect, on HIV, we've seen, a lot of amazing work happen with, indicators, but a lot of those indicators have taken us years to work on, decades even, and the measurement and, building up the systems has taken a long time. We've come to global consensus around, case definitions of COVID and surveillance systems for COVID, and, our world in data and other systems that, ECDC and WHO and other organizations have built up have happened in less than a year. And that's incredible. And so I think that, just to see what we can do when we work collectively, across countries and across our different silos professionally is really amazing. And it gives me a lot of hope to, what we are capable of. And I think that we should expect and, raise the bar a little bit for what we can achieve collectively on a global level with other areas of infectious disease and non-communicable disease going forward.
I'll go next. Whatever, I can't, I'm not a virologist, and I can't speak directly to the question, but I'll just pick on a couple of things that Anastasia said. That whatever comes in the future, and something will come in the future, and I suspect in the near future, that I hope we've learned enough lessons now. And the lessons are basic for the most part. Solidarity is a big part of the lesson. Equity is another big part of the lesson. And my glass half full assessment of the COVID-19 response has been that compared to HIV that Anastasia mentioned, I feel as though we were more quick to recognize the equity implications of COVID-19. Whether or not we responded well is a different issue, but I really appreciated the speed with which people sort of knew that this thing is going to mess us up if we are not alive to the equity implications. And I hope that if something of this nature were to happen in the near future, we will be even better at actually then implementing those concerns around equity that we would have.
Fully agree with that. And just to pick up from those comments, I mean, I think looking forward, hopefully before too long, the issue will be an equitable and resilient recovery. And that's the flip side of the harsh light being shone on the inequities. That's point one. Point two is we have to avoid the cycle of panic and neglect. I mean, historically, these outbreaks, epidemics come every few years. We know that. There was SARS 2003, there was H1N1, there was, MERS, now there's SARS-CoV. I mean, it's not a surprise. So we have to not fall into that cycle of panic and neglect. And thirdly, I just wanted to emphasize the importance of primary health care in that resilient and equitable recovery. You know, primary health care people equate to essential services. And the historical record, sometimes even a subset of essential services. That's not really what primary health care is about. Primary health care is about essential services, and it is about on the path to universal health care coverage, but it's also about essential public health services. So it's about pandemic preparedness. And it's also about community empowerment and community engagement, which is very important in equity. It's very important in resilience and preparing against and protecting against future pandemics. And it's also about multi-sectoral approaches, which are of course needed for healthier populations, but also for, as we see in COVID, resilience and pandemic preparedness. So WHO's triple billion goals of 1 billion more people with universal health coverage, 1 billion more people living healthier lives, 1 billion people better protected from health emergencies. In a sense, primary health care is the glue, and that's what we've seen through COVID, the glue that binds those goals together. And so looking forward, I think that planning is important. I think it's coming. And I think it has to be focused on an equitable and resilient recovery, powered by, to quite a considerable degree, primary health care at the country level, embedded in countries, led by communities, led by countries themselves, and with a very, very strong role of governments and a very, very strong role of multilateral governance at the global level.
Thank you very much. I would like to thank all the panelists for today, really, and for all the wisdom and all the thoughts and the comments and your experiences that you have really shared throughout these set of slides. So this came to an end. Is there any final comment from any one of you? You are very welcome as well before we end the session.
Just want to say thank you, and I've learned a lot in the discussion. So thanks, Ziad, for organizing and for your leadership in promoting these discussions and this Facebook group. And thanks a lot to Seye and Peter. It's been really interesting.
Thanks.
And basically what I have to say is what she said.
Me too. So thank you.
Thank you all. And also again for the weekend, have a good weekend, everyone, as well.